My name is Angela Powell. I am presenting an intervention to treat child and family traumatic stress. This intervention is effective to treat children between the ages of 7 to 18 experiencing any kind of traumatic event. And it is wise that they seek treatment immediately after the event occurs in order for this treatment to be absolutely effective. A traumatic event is one that threatens injury, death, or the physical integrity of self or others and causes harm, terror, or helplessness at the time it occurs. A significant number of children in American families are exposed to traumatic life events. Children and adolescents vary in the nature of their exposure to traumatic experiences. The reactions are influenced by their developmental level, ethnicity, previous trauma exposure, available resources, and pre existing child and family problems. The impact of trauma on children 7 to 18 years encompasses race and ethnicity, poverty status, and gender. All affects children's risk of exposure to trauma. Significantly more boys than girls are exposed to traumatic events in the context of community violence and serious injury disproportionately affects boys, youth living in poverty, and Native American youths. Also, traumatic stress can leave scars for a lifetime, and, and exposure to multiple events over the course of a lifetime can result in a range of behavior health problems, including PTSD, uh, symptoms such as separation anxiety, particularly in young children, sleep disturbances, nightmares, loss of interest in normal activities, reduced concentration. Other issues include substance abuse, depression, childhood behavior disorders, psychosis, and some personality disorder. Society and social workers should care because exposure to traumatic events occur in at least 50 to 60% of US population. Social workers should widen their scope to encompass abusive situations such as domestic violence, physical and sexual abuse, neglect, death, and other life events, to include today's issues such as gang violence, school shootings, natural disasters such as flood and hurricane, acts of terrorism, and war experiences. These impact youths today, and these traumatic events can have life threatening responses that can affect the child and the adolescents for a lifetime. Also, social workers should incorporate a trauma enforced perspective, which is a positive approach to treating families. A trauma informed perspective asks clients not what is wrong with you, instead, what happened to you. When children, adolescents, and families come to the attention of helping professionals, the identified trauma may not be the one that is most distressing to the child. For this reason, gathering a thorough, detailed history of trauma exposure is very essential. The intervention model I chose is cognitive behavior therapy and a child and family traumatic stress intervention. I chose these two interventions to look at because the quality of therapeutic relationship among therapist and parent is the foundation of the treatment of trauma. And these two interventions model that. They are safe, secure, and trusting therapeutic relationship which support recovery processes and encourage children and parents to do the hard work of dealing with the impact of a traumatic experience. The first one, cognitive behavior therapy, is a technique that has been shown to be effective in treating children and adolescents who have persistent trauma reactions. CBT has been demonstrated to reduce serious trauma reactions such as PTSD, other anxiety and depressive symptoms, and behavior problems. Child and family traumatic stress intervention is the treatment that I am stressing today for child and family stress. I believe I am introducing this treatment because it's a stressful event. The treatment I'm introducing to you today that I feel is very effective and is rightful for treating children and family traumatic stress is proven to be more effective as an early intervention in the early stage of exposure to the traumatic event. It is an early intervention and secondary prevention model aimed to reduce traumatic stress reaction and post-traumatic stress disorder. Its treatment is effective when intervention occurs within 3 months of exposure to PTE. Treatment emphasizes parent and caregiver interaction. A brief synopsis of this program. It focuses on 2 key risk factors of poor social or familial support and poor coping skills in its effort to prevent chronic PTSD. CFTSI ameliorates these risks by 1. Increasing communication between the affected child and his or her caregivers about feelings, symptoms, and behaviors with the goal of increasing the caregiver's support of the child. And 2, providing specific behavioral skills that are taught both to the caregiver and child to assist in coping with symptoms. In the first session, a therapist meets with the parent or caregiver alone. A series of questionnaires are completed to assess the parent-caregiver psychological status throughout the intervention. Then they discuss external stressors related to the PTE and a case management plan is set up. The second session occurs as close to the first session as possible. A series of questionnaires similar to session 1 are also completed by the child. Then answers from both participants are compared. Areas of agreement are praised and areas of disagreement are seen as opportunities to improve communication. Parent-caregiver will be more aware, receptive, and supportive of the child. The therapist then give parent/caregiver behavior skills modules as homework. Session 3 includes all 3 participants, the child, the therapist, and the parent. The child completes questionnaires with parent providing perspective on the items mentioned. Main emphasis is on adjustment of communication efforts to improve the effectiveness of behavior skills modules as well as other supportive measures. The final session, almost identical to that of the third, with the end of the session focused on future check-ins and possible plans for more extensive treatment. In assessing this intervention, I find that a pilot study compares baseline interviews and first treatment sessions occurring at the initial visit within 30 days of the youth's exposure to post-traumatic event. At the 3 months follow-up, youth had significantly lower post-treatment and anxiety scores than comparison youth. Findings suggest that there is a reduction in the odds of PTSD by 65%, a reduction in the overall odds of partial or full PTSD by 73%. So it is, I conclude here that CFTSI also reduces symptoms and promotes recovery more quickly than the comparison conditions. CFTSI effectiveness, the effectiveness of this intervention is demonstrated in the findings at the end of treatment. The role of family as a primary protective factor for children exposed to PTE, demonstrated in families with extramarital abuse and a decrease in children's symptoms when the non-offending parent is able to provide support. Optimum support requires communication between caregivers and affected child. CFTSI enhances communication by using well-established PTSD and mood questionnaires as vehicles for identifying and discussing the child's difficulties and focusing on understanding and reviewing agreements and discrepancies between reported and observed symptoms of PTSD and depression. Once symptoms are identified, CFTSI teaches caregivers and youth specific coping skills to manage those symptoms. CFTSI was originally a Yale study, which is being adopted by therapists as an effective treatment for child and family stress. The intervention is facilitated by a therapist manual, and it contains detailed case vignettes, a decision tree for identifying child and family traumatic stress cases, and easy to read handouts for children and caregiver. There's also a Spanish language version of the clinical assessment tools, which are available. The validity of this intervention is that post-traumatic stress and anxiety symptoms were significantly lower in post-treatment and remain lower at follow-ups. The current results suggest that CFTSI offers promise effective for just such an evidence-based early intervention. It also identifies exposed children in need of early intervention, which is grounded in the positive factors that support resilience and recovery should be able to prevent PTSD symptoms and the development of other disorders. I conclude, based on my research, that CFTSI is an effective treatment for early intervention after exposure to any traumatic event. It emphasizes the child and parent relationship and uses communication as a very important factor in healing. And I would like you to follow this link, and you can view child and family traumatic stress. You will get a first-hand look at what the treatment is like. A presenter will walk you through, and you will see how it is applied, when it should be applied, and how effective it is. This way we can eliminate some of the issues that are preventing families from getting help. And as you note throughout this presentation, that early intervention is the key for child and family traumatic stress to be effective, to eliminate child and family traumatic stress. Early intervention is the key. I thank you very much, and this is the end of my presentation.